Okay, I'm sorry, I picked the first specimen because it's hateful. It's making everyone so mad at me.
I enjoyed it.
Thank you. I enjoyed it too. All right, so we have a long bone from a pig, I think.
Yeah.
Can everybody appreciate that this bone is not the right size or shape? So if you look really closely, you can actually see a line where normal cortex was. It's about there. So everything outside of my thumb basically is extra added bone. So we've added something. It's also not bone shaped anymore. It's kind of a triangle. Not the right, not correct.
Do you know what kind of long bone?
I would guess it's like maybe a femur. So I think this could be a knee. I think we're femur. Don't quote me on that.
I thought it was on bar.
You're right. It's a hawk. So it's a tibia. Yep, correct. All right, and then on this piece looks a little different. So here you can still see the normal outline of where the normal cortex used to be. There's a little thin line right there. All this is added, and over here it's little islands. So there's little islands of bone that are just kind of floating in this really firm white tissue. Another change I notice about this is the muscle. So this is a tibia. We should have pretty significant muscle, except on the front aspect. We have replaced a lot of this muscle. So here's normal muscle. We've lost a lot of this. Here, right here, there's a little tan strip of very pale, this is atrophic muscle. It's just barely hanging on. And then all this white stuff is scar tissue. So if you think about how this would feel in the animal, if you had all these little spikes of bone coming off your long bones, that would hurt, right? That would hurt a lot. So this is causing damage to the tissue around, to the soft tissue, the muscle. It's causing inflammation and scar tissue. All right, so the reason everybody hates the specimen, and it's confusing because we've added something. Is it hyperplasia or hypertrophy?
Oh,
It's kind of a hard question to answer, right?
Yeah.
How much of bone is cells? Not very much. It's mostly extracellular matrix. So there probably is a little bit of hyperplasia of osteoblasts going on, but most of the added tissue is matrix. We're increasing the size of the bone. We're not really doing a whole lot of cellular stuff, right? We're mostly just taking our existing cells, laying down new bone. The osteoblasts in here, if we look microscopically, they will probably be hypertrophic and hyperplastic. But this lesion, this condition is also called hypertrophic osteopathy, right? So if I told you it's called hypertrophic osteopathy and the microscopic finding is mainly hyperplasia, you would hate me even more. So this is probably a mixed process: hyperplasia, hypertrophy, also inflammation, scar tissue, atrophy of the muscle. Did anybody notice the atrophy? Pretty subtle, right? So again, that's that search satisfaction. After you find one major thing, keep looking. There's probably other changes. This lesion caused another lesion, right? It caused scar tissue. It caused damage to the muscle, atrophy, inflammation, swelling. Look how swollen this is. And it's not all just bone. We've increased the soft tissue too. Questions about this? Yeah.
I can't remember word for word what it said on the document. It said it came from something going on to the lungs.
Yeah, so hypertrophic osteopathy, pathogenesis of this is totally unknown. There's like 4 or 5 different proposed mechanisms, none of which are particularly convincing. It's kind of a good principle in medicine. Whenever you have multiple answers or where there's a lot of treatment for things, it means we don't know the best treatment, right? Because if there was one best treatment, we'd be doing that. We wouldn't be doing all these different things. So because there's 4 or 5 different pathogeneses proposed for this lesion, it tells me that we have no clue how this lesion occurs. But yes, this hypertrophic osteopathy. It's periosteal new bone forming on long bones. Usually it's distal, so it can be like on the digits, on the distal radius humerus, tibia. But yeah, pretty strong association with space occupying lesions in the chest. So lung tumors, tuberculosis can cause this, can be inflammatory or neoplastic. No clue what the cause. This lesion is not sensitive for intrathoracic disease. So if you don't see it, you can't say there's no disease in the chest, right? So we only see this sometimes with disease in the chest. It is specific, relatively specific for disease in the chest, but it's not sensitive.
I guess I don't have a lot of experience with like seeing normal bone specimens. So like I thought the like medullary part looked weird and cheese-like.
It does because it's been fixed for a long time and that's fat.
Oh.
This specimen is ancient.
But normally we'd expect the medullary part to be bigger.
The size of the medullary cavity is fine.
Oh, it is.
The content looks weird and chalky.
Okay.
Because it's been fixed for
Oh,
years.
so it grew, the cortical part, it grew outward, not inward.
It's growing, this is periosteal new growth.
Okay.
You can see that especially in this specimen because you can see where the cortex is and all the new bone is here on the surface of the cortex. It's periosteal new bone.
I know we don't know the pathogens for osteopathy, but it has like some species.
I associate it with kind of like dogs. I think it happens in humans. This is a pretty uncommon lesion. Yeah, so that's a hard question for me to answer because I don't think I've ever seen it in real life. Even this specimen, this was here before I got here. I never saw the case. I've never had a case of this yet. Someday. Another? Bring me that kidney. Yeah, I love that kidney. Okay. So this one is confusing because is this an added or lost situation?
It was, I really can't lost.
I hear a lot of both answers.
Sorry. Fluid buildup wise, I think it's like emptied out on the body.
Either displaced.
There seems to be less cortex
Good,
and more pelvis.
good. And
Big.
it's huge. This kidney is too big. We have added something. Has to be added to get a giant kidney. But when you open it up, we haven't added kidney tissue. In fact, we've lost kidney tissue. It's empty inside. So what was in here was fluid. This is an ectopic ureter. So that means the ureter where it entered the bladder was coming in an abnormal way where it couldn't completely empty into the bladder. They did imaging. They saw there was reflux from the ureterovesicular junction. Vesicle is bladder. So ureterovesicular, UVJ. There was reflux. So it's not completely emptying and they saw it was actually squirting back up into the ureter. So obstruction, pathogenesis. Obstruction, fluid builds up in the ureter. Did you guys describe the ureter as well? This is also way abnormal. It's like a hose. It's huge. It's massively dilated. The wall is super thick and it's tortuous. That's another word. Tortuous means like winding back and forth. Yeah.
So how do you know that it's not the same amount of tissue that's been like?
Look at it.
squeezed? But like, could it have just been like pushed together and squeezed? And
What happens if you put this much pressure on tissue?
it dies? Right?
It dies. Let's use our path words.
Atrophy.
It atrophies. So I know by definition, this has caused pressure. This is atrophy. If you feel it,
Yeah.
feel how thick the cortex is.
So if it was acute, then there would not have been atrophy yet. It would have just been pressure.
Atrophy is not acute. Yeah. Atrophy takes time. Most of these adaptations take time. Degeneration, necrosis can happen pretty quick. Adaptations take time. Hypertrophy, hyperplasia, atrophy, neoplasia, all take time. Okay, other questions?
Why are they different colors?
Well, this one I think was a necropsy kidney. So it was maybe a little less fresh. This was a biopsy kidney. So it came immediately out of the animal and into a germ fixative. This is like the freshest you can get. I think the color is from blood. I think there was a lot of blood in this kidney because usually when we get spleens, they're the same color, like biopsy spleens. This is just like death colored, like the blood's drained out of it and it's gray. This, they like had to clamp off the vessels, trap the blood inside. Super fresh.
Do you remember why the other?
I don't have any idea who this belongs to. Is it even a dog? I'm not sure. This might be a ruminant. This could be like a goat.
Is it the same issue that's going on where we're?
I can't tell, right? What all can we tell about this kidney? What is the most we can say about it that we know for sure? The animal's dead. Do you know that? This one's alive. This was a biopsy. This. Yes.
Yeah.
All you can really say is pressure atrophy and yes.
So we can do the same thing. Has something been added or lost from this kidney? Yes. We've lost kidney, we have atrophy of the cortical tissue, and we've added fluid in this space. This is exactly the same scenario, except here I know the cause because they told me this animal has an ectopic ureter. Here, I don't have a history. I don't remember who this came from. I don't know what the cause of this is, but it's probably an obstruction somewhere. If this is a goat, if you tell me these are goat kidneys, I'm going to say this probably has stones in the distal penile urethra, because that's the goat thing, right? Could have a tumor somewhere, could have a bladder tumor, could have really bad inflammation in the bladder or in the ureter. I don't know.
Does like the poppy kidney condition look similar to that?
What?
Poppy kidney.
What's a
I've heard
poppy
of-
kidney?
I don't know exactly what it's called.
Poppy like poppy seed.
Something like that. Yeah, we learned about it in the micro, I think.
No idea what that is.
Okay, cool. I'll figure out what it is and I'll ask you a question.
Is it polycystic kidney?
Yeah. Yep. I think that's it.
Where it looks like it's like a bunch of little cysts. What was the question?
That was what it looks similar to this
Nope.
because different fluid is accumulating.
It's
in different places.
it's different fluid and it's accumulating in a different place.
Okay.
So those are cysts in the cortex. So you'll have like a bubbly cortex. This is an obstruction. The fluid is building up in the pelvis. Okay. Because that's where it goes. Right.
In this kidney, or both of them, you would describe the dermatitis as atrophy,
Yes.
and then you could say like, because you're, as far as describing the lesion, you're describing the kidney, right?
If I was, so I'm describing the kidney and the ureter for this one because it has both. So if I were to describe this, I would say unilaterally, the right, left, whatever kidney this is massively enlarged up to like 2 or 3 or 4 times normal, depending on what breed this is. I would say that the pelvis is massively dilated and that the cortex and medulla of the kidney are thin and compressed. Those would be my descriptives. For the ureter, actually, there's another lesion here. Did everybody see this adhered to the kidney? This is omentum. So when omentum adheres to something in the abdomen, it means there was something bad there. So omentum is like your abdominal Band-Aid. So there was either some inflammation or potentially a little bit of rupture here. Maybe the capsule split and some urine came out. So that's also something I would describe because that's a marker of injury. And then for the ureter, I would say the ureter is diffusively, massively dilated with thickened wall and tortuous profile.
How do you get momentum on a kidney if the kidneys are right?
That's a good question. And I realized that as soon as I said it, it didn't make any sense. This is probably just retroperineal fat that's adhered. Same principle, not momentum. Thank you.
But it could have ruptured.
Yeah, same. It is because it's adhered. Your capsule should not normally be tightly adhered to your kidney. You should be able to peel it off. If it's adhered, there's pathology there. Good question. Thank you. My bad. Anatomy's hard. This goes to show you don't need to remember everything in anatomy for long-term success. Short-term success, definitely. More? Bring me another. Esophagus. Or the esophagus, if you're European.
It's not pronounced, right?
I think so. They even put an O in diarrhea. Diarrhea. Esophagus. Esophagus. All right, this is an esophagus from a horse. Proximal is a little bit thinner. Distal is a little bit thicker. None of this is normal. This is diffusely. Again, I'm using the same words because the specimens I'm showing you are usually pretty severe. The muscular layer of the esophageal wall is diffusely, massively thickened. more severely so at the distal end. I would say how many times normal? Or did-
30 versus 30.
I already said it? 30? Sure, that seems appropriate. Maybe 50. I don't know. I'm pulling these numbers out of my butt. Normal esophageal wall, pretty thin. So that's probably the most prominent change. There's also some other changes I would describe. I would say the lumen of the esophagus is moderately to markedly dilated, right? So usually your esophagus is like pretty flat and closed unless something is sliding through it. So this is dilated. It's a mega esophagus. And then probably the most subtle thing in here is I think this mucosal lining is too thick. But it's diffuse, so it all looks the same, so that can be a little bit harder to appreciate. That's something you guys might not appreciate at this point, but that's fine. So, all right, what did we decide the change in the muscle was? Hypertrophy, because it's muscle, it cannot be hyperplastic, and we've added, so it has to be one of those options. What about in the mucosa? I said the mucosa is thicker than normal. It's hyperplastic. Why is the mucosa hyperplastic? Well, it's hyperplastic because it can be, but why in this case is it not normal? Why is it hyperplastic?
To allow certain peristalsis.
To protect from the food that's in the esophagus getting stuck.
It's getting stuck?
They get choked.
So you think this animal would get choked from this? I agree. If that's the part of our esophagus that goes into our stomach, how much horse-sized food is passing through that? Nothing, unless he's eating like smoothies only, which he should be at this point. Like, it's hard to even get a finger in there. It's pretty tight. So this is another obstructive lesion. We have obstruction at the distal part. It's causing the proximal part to dilate, similar to the kidney, right? Except we're in a different tissue, so it has a different response. Rather than atrophy, the muscular part, which is trying to squeeze things past the obstruction, that's an increased workload. It's going to undergo hypertrophy to try to move things through. Yeah.
Can you tell which part is the part that?
I know the pathogenesis of this disease, and I know that distal esophageal hypertrophy is usually the more severe, and that proximally it's less. Otherwise, yeah, would not have been able to tell from like the anatomy of this. Yeah.
So is the horse choking because of the hypertrophy, or is the hypertrophy because of choke?
Let's open that one to the group. What do you guys think? Hypertrophy first? Choke first? Not many devil's advocates. I agree, hypertrophy first. This is causing obstruction. This is not the result of obstruction.
So it's not hypertrophy due to, I know the paper says it's Freesians, it's just a genetic thing that happens.
Yeah. This is kind of similar to HCM in horses. We do see this in other breeds of horses as an idiopathic lesion. It's often less severe. This is so severe, if this wasn't a Frisian, I'd be shocked. But we can see this lesion in other horse species. It's again mostly prominent at the distal, and it increases your susceptibility to choke. Hold on questions. Let me finish describing this real quick. Okay, so change in the muscle, hypertrophy. The mucosa is too thick. It's hyperplastic because again, this is obstructive. We have food stasis in here, which is irritating. So our mucosa is becoming hyperplastic to protect. Resume questions. Yes.
The paper said that it could be reversible, but how could it be reversible if it's genetic or idiopathic?
All of these diseases are reversible if you can remove the inciting cause. What is the inciting cause in a Frisian? It's a Frisian. Can you ever remove its Frisianness? Not reversible. What is the cause in other horses? I did say that. Can we remove something that's idiopathic? We don't know what it is, so we can't remove it. Not reversible. These are theoretically reversible if you remove the cause. Often the cause cannot be removed, so it won't be reversible in real life.
I had a question about the fat adherence portion of it. Is
Yeah. That's just fat.
is it normal?
It's fine. Yep.
Question about the esophagus adaptation in other animals. We had kind of thought that it was like a widening.
It is.
Is it always associated?
That's what I'm referring to, the widening of the lumen as megaesophagus,
Not the thickening.
not the thickening. The lumen is big. That's why I'm calling it megaesophagus, not because it's thick.
You said the lumen is big. The mucosa is taking up the space. Yeah. Just on.
At the distal end, the lumen is not big. The lumen is small. It's obstructive. Up here, proximal to the obstruction, it's dilated.
That's what mega.
Yeah.
It's soft. Okay.
They had the proximal end that's more dilated and then less likely to have the respiratory problem.
Oh, respiratory problems. So I can't comment on respiratory problems with this animal because I don't have its lungs, right? The respiratory system could be fine. I don't really think of that as a proximal distal thing. I think of that as an extent of severity. It's going to take severe dilation of the esophagus to cause enough respiratory compression to cause respiratory signs. I think this animal is much more at risk of aspiration pneumonia than he is of like compression in his chest. Because this isn't that big of a dilation, really. Because structurally, this thing can't dilate very much. This is so firm, right? It can only get so mega. It's a mini mega. Another? This format, okay? Okay. New this year for you guys. Feedback appreciated. Oh yeah, bird feet. Delicious. Okay. We have some hawk feet and some chicken feet. Could everyone tell which is which? These are predator feet. These are feet for eating. All right, so this is really the same change in the tissue, same tissue type, same change. This is a multifocal lesion. This is a diffuse lesion. Does that make sense? So here, I would describe these feet as multifocally, bilaterally. There are multiple variably sized, often coalescing, raised cauliflower-like proliferative lesions on the feet and toes. For this one, I would say the distal limbs, legs and feet are diffusely crusty, scaly. There are numerous cracks. There's some reddening. See how red that is right there? So there's some signs that these are inflamed. They're just very thick and crusty and gross. There's also a little bit of nail deformity. So this spur is kind of crusty and janky and deformed. Janky is a descriptor. It's fine. All right, so what is the process? Incorrect. Have we added or lost? Added. What are your choices for adding? Hyperplasia or hypertrophy. This is foot skin, so it's going to be hyperplasia. Excellent. So this is multifocal nodular epidermal hyperplasia. This is diffuse epidermal hyperplasia. This is poxvirus, avian pox. This is a mite. It's called the scaly leg mite. We just call it like we see it. That's why pathology is the best. We name all the diseases just based on what they look like. Scaly leg mite causes scaly legs. This is called Nemidocoptes. It's a KN. K is silent. Nemidocoptes. Mutans. Questions? Yep.
I understand we're going to reverse.
Yep.
When we first looked at the hawk, it almost looked like necrosis, just like the blockening of the tissue. Is there like a way to like distinguish between like if that would be reversed?
You're right. There is some necrosis in here. Necrosis often goes along with poxviral infection. That's a good pickup. The big change I want you to recognize is that this is hyperplastic. But yeah, that brown, black, some of these areas are starting to be kind of friable. That's also, there is also necrosis.
Poxvirus one is contagious. Well, the mite one.
Also very contagious. Yeah, both contagious. These are both reversible. If we take away the virus, take away the mites, these feet will go back to normal. Maybe not some of these like deformities, like the nail. If once the nails get involved, that could be kind of weird. She'll never be a show chicken again. Great questions. More, please. More questions, more specimens. Yeah, 10 more minutes.
Oh, yeah.
Grab the brains. Request for cheese brain. All right, all the cheese is still in the brain. It survived for 3 hours. I'm so proud of you guys. Thank you. Okay, so it comes apart. It's like it fell apart like Legos. We have a little abscess, right? Caseous necrosis inside. Looks like cheese, right? Looks just like cheese. Caseous necrosis, capsule. What is the process going on in the brain where this thing was? Like, so this is the abscess. It's causing what? Atrophy. It's like we dropped a bowling ball in the brain, which is very, very soft. The brain does not respond well to being compressed, and everything compresses it because it's so squishy. This is a fixed brain and it's still very soft. In a fresh brain, you guys will see once we do the necropsy labs and I show you a fresh cat brain once we take it out. Brains are so soft in their fresh state that they start falling apart just being like held in your hand. They will literally start melting and leave like brain slug trail on your hand. So brain is super, super soft. Anything massy is going to cause compression, atrophy. So how do you guys think this animal presented? Neurologic. Good. Yeah, for sure. What kind of signs? Seizures?
Maybe ataxia.
Cranial nerve dysfunction. That one I'm not sure about because we're not in brainstem. We're not really near anything cranial nervy. So that one,
Maybe visual impairments, like
we're like temporal. We're like here-ish. Behavioral changes, seizures, ataxia, not vestibular. Vestibular, you have to be ear or brainstem. Other questions? Concerns, comments about cheese brain? The disease is caseous lymphadenopathy. When we're saying that disease, we're referring to an organism. The presentation can be lymphadenopathy, but they can also have visceral and brain abscesses. The disease is called caseous lymphadenopathy. It often involves lymph nodes, but goes other places.
But that's the same disease as that. I see it in like how many here.
Yeah.
Would it likely be that other lymph nodes on that sheet?
Can't say. Can't say. Sometimes it's goes everywhere. This might be the only lesion. Sometimes we have solitary abscesses in weird places that are not lymph nodes. If you see a caseating abscess in a small ruminant, you should test that animal for CL because this is a very contagious disease.
What is the country that impacted because you're like away from that?
So how are you going to diagnose CL in this animal? Necropsy? I think so.
You're gonna do a biopsy.
You're not going to biopsy a sheep brain. That's not, you're not going to find any large animal vet willing to do brain surgery. If you do, please text me their name and number. And I would like to speak with them. Be like, why is this your career choice? Who's paying for these edible animal brain surgeries?
I had another question about like it's it affects macrophages. They're in the bloodstream. Bloodstream clearly goes to the brain. Like how then does the like abscess like start to form? Like it's inside blood vessels? I guess it's
There's
like how
that's a complicated question because it's brain. There's a blood-brain barrier.
yeah.
Yeah, I'm gonna decline to answer that until next year. That's it says path question. Okay. I do teach you guys CNS next year. Remind me, back to it.
I'll forget.
Hey, remember that cheese?
You want it.
What? No, I'm done with it. Done with cheese. I love these guys. They're so cute. They are though. Stop it.
Is this like a sadly?
Oh, in a horse stomach, this is pathognomonic.
Yeah. When you see it,
Also, that's not really fair because when you see it, they're gonna be in there. So like if the agent is this big and staring you in the face, it can really be pathognomonic. It honestly feels like cheating. But if I showed you just this and I said this is a horse, you could be like, that's bot flies, 100%. Okay, so these are incidental. We see these in like almost every horse we open and they cause no clinical signs, no problems. Nobody cares. All the vet students care. They're like, ew. The horse, they're disgusting. Horses are the worst. Don't go into equine practice.
Would you like to go?
They're just giant colons on 4 toes. Not a good day. Okay, so I had a really good discussion with someone about why are they right here at the margo? It's the margo plicatus, right? Non-glandular stomach, glandular stomach.
For this like up.
Out of the acid, so that'd be up here. So I want you guys to think like worms. You don't want to live in that, you want to live up here, right? That's the safest place for you to be.
But I think they can eat the protein.
But where's the easiest place to get access to food and nutrients? Down here. So I've got a conundrum, right? It's safer up here, but there's more food down here, so I'm just gonna split the difference and live right on the line. Does that make sense? That's literally what they're doing. That's the best of both worlds. Did everyone appreciate that these are ulcers? These are chronic ulcers. It's a hole in the middle with a hyperplastic rim of tissue. So hyperplasia trying to cover the ulcer. Is this reversible?
Yeah.
Theoretically, yeah. If the worms go away, these will heal. In fact, the pathogenesis of these things, somebody asked me last hour, these come from flies. These are baby flies. Flies lay eggs around like the feet. The horse will like, itchy. They swallow the eggs. They turn into larvae in the stomach. Larvae attach. Eventually, these will pupate, fall off, and be passed in the feces. Turn back into flies. So after they fall off, these little ulcers will be able to re-epithelialize and cover and get back to normal, right? So it's reversible. But we got to take the worms away.
But there's like within the ulcer, there's necrosis, and like those cells
An
are.
ulcer is necrosis.
Ulcer.
If you have necrosis on a mucosal surface, that'll result in an ulcer because those cells will be falling off.
Okay. But,
Sorry to interrupt you.
oh no, that's okay.
Yeah.
It's just like that. I struggle sometimes with that. With like the regeneration possible, like it's those cells are dead. New cells take
You
over.
can replace them. So the necrosis is irreversible. These cells that were right here in the middle are gone forever, but we can replace them and cover it with new cells. So we're going to talk about that a lot in repair and like chronic inflammation week, how that works.
So some of the holes have like three like a hole, 3 holes in a hole.
Uh-huh.
Can you explain that?
Worm party. Like 3 really close together little friends.
Yeah, it's just the
Yeah. Yeah, we'll just share this ulcer. This little 3-pronged ulcer.
I don't want to go too far. They were munching on a piece of straw and met very long. Or just like in the summer. That's sorry. Do you only see them like in the summer or like
All
day long?
They're all
All the
yeah.
time. Okay.
lots of them everywhere all the time. Horse dung.
So they don't get like parasites from or
They are parasites.
But if they
You
don't,
mean, do the parasites have parasites?
Yeah.
I don't think so. Not that I know of. That is a thing in chickens.
they eat.
There's a chicken disease that's like a Russian nesting doll. It's like an earthworm, and inside the earthworm is a nematode, and inside the nematode is a protozoan, and inside the protozoan is bacteria.
It's not the bacteria, the virus.
No, we've only gone down to the bacteria. Maybe. There could be those. Bring me another. Issues for my feast. Bacon. All right, did everyone recognize this from my slides?
Yeah.
It does exist. It's real. So here's kind of the more normal. He's got the little butterfly shaped turbinates. These guys less normal. We have clearly deviated snouts. These are not normally shaped. We've got bulgy over here. This one's also a little bulgy and weird, a little crooked. We have loss of turbinates. So we've lost something. This is atrophy, turbinate atrophy, because this is atrophic rhinitis, super common in pigs. Questions?
It's the smallest one or
Yeah, close enough. Close enough for our purposes. He looks a little crooked when I look at him this way, but his septum is not deviated and his scrolls look fine. Normal enough.
Is the hard spot on the middle bone the deviation, or is it because of rooting?
This is a scab. I don't know why it's here. Rooting's a good theory, but pigs also often like fight and bite, and they're often covered in scratches when they come to necropsy. So I don't know what this is from, but yeah, there has been some trauma here. There's a little scab. Nice pickup. Anything else? Classic Navly stuff. Another? A horse esophagus. One has strong feelings. That one's pretty cool. Oh, a foot. All right, alpaca foot. What did we think? Added or lost? We've
Yeah, this one
lost
was the one.
90% of the alpaca.
Oh.
I see mostly added here, I think. We've added a lot of dark red crusty tissue to the foot pad. I would say the foot pads are, it's not quite unilateral. This one's affected too, but this one is worse affected. I would say the foot pads and the digits are expanded by dark brown to black, firm, crusty tissue. Yeah.
So why did it say necrosis versus hypertrophy?
Because look at it. This is dead.
Oh, okay.
So necrosis can also result in an increase if it's very acute because you get a lot of swelling. Remember, necrosis is inflammatory, so you're adding inflammatory cells to the tissue, so that can be something added in the acute phases with necrosis.
So if it's hyperplasia, it look more like.
If it was hyperplasia of this tissue, this is epidermal tissue, so it would be like papillary. It would look
Like the chicken feed, right?
it would look a little bit more like the chicken feet, especially the chicken. Yeah, the chicken, not the hawk so much. But this is dead, nasty, brown, crusty, wrong tissue. Other questions? Court adjourned. So remember that necrosis does not have a specific appearance. It can be one of the more challenging ones for you guys to recognize. When you see things that look dead, tissue that looks dead. Does that make sense? I say it looks dead. Can you guys all appreciate that this looks dead? Not healthy. Often, yes, but that's only present in acute. So we're talking on a spectrum, right? So very super acutely, you will have ongoing hydropic degeneration, which can cause swelling. You'll have acute inflammation, which can cause swelling. You'll have fluid in the tissue, which causes swelling. Over time, you're losing tissue. So you'll get a little bit of a loss or a depression or a sinking. Eventually, if this progresses, this is going to slough off and you'll have like a big ulcer, right? Does that make sense? And then it's going to go into healing phase and we're going to start proliferating again. We're going to start laying down scar tissue, trying to lay down new epithelium. So we're always kind of on that spectrum somewhere. Disgusting, take it away. More? Is there treatment for that? I don't think so. I think euthanasia is probably treatment. The chair, give him the chair.
Oh,
Oh, a Bailey chair?
I'm just joking, cause you know, they put the dogs.
A horse in a
chair.
Bailey chair. I don't think that would work because he's still obstructed. I almost rotted some butter for you last night. I was like, I should bring it and just like put it in a little jar in the corner, like mimic the smell. In real life, this stunk so bad. So this is not a great specimen. It's very aged. It was bequeathed to me. This is normal muscle color when we're fixed. This has been sitting in formalin like since before we all were born, probably. This is an years old specimen. It's been here at least 5 years because I started 4.5 years ago and it was here when I got here. All right, so this is the normal color. And what we're looking at is this kind of poorly demarcated dark black area. It goes in on the cross section, so it's not just a surface change. It actually goes in the tissue. This is black leg. Just call it like I see it. So this is coagulative necrosis. Do you see how it still has muscle texture? It still looks like muscle, but it's black and dead, and it would smell really, really bad. So this is an example where necrosis happens so acutely that we're not in an added or lost, right? So this like just happened. The body hasn't really had a whole lot of time to respond to it. So we don't have swelling, we don't have shrinking, we don't have loss of tissue yet. That's coagulative necrosis. It happens so fast that everything is like frozen in place and it doesn't know it's dead yet. That makes sense? Yes. Yeah.
So didn't we say for coagulative, the region is sharply demarcated?
Oh, it often is because it's often associated with ischemia. This is not an ischemic lesion. This is a toxic lesion. So it's not so well demarcated.
And then how would we know it's not a gangrene, which is?
It is. This is blackleg. This is technically gangrene.
So it's coagulated and gangrene.
Gangrene always starts with coagulative necrosis, remember? And then it depends what happens to it. Is it wet or dry or gassy? So gangrene is coagulation necrosis plus the stuff that happens to it after. Eventually this would liquefy because there's bacteria in here digesting it. So it's going to start with coagulative and then it's going to become the gas gangrene, stinky, nasty, bubbly. Awesome questions. Thank you. Lovely assistant.